Okay, it's recording. Good, fantastic. And I'm going to screen share. I am going to screen share. There we go. Apologize, took way too long. Screen 2, good. All right, so if you are looking at my screen, please give me a thumbs up. Can you see? Yes, okay, good. You make it all big. All right, everybody, so today we're going to talk about chronic kidney disease, and here's a little bit of the agenda. I'm going to do a Kahoot to see if you can recall some of the items from last week. Cross your fingers, hope you do good. And I made them actually a little bit challenging rather than pretty simple. So if you've kept up with your reading and you've kept up maybe listening to the different PowerPoints and such, you should really do good. And I did some farm in there too, because I know that's your favorite. We're going to review a basic overview of kidney disease. I found it from the Osmosis YouTube channel. It's not bad, a little bit on the heavy side up front, but then the second half of the video is very applicable to what we're going to be learning and talking about. Then I can show you guys, we're going to let you go on break. We're going to do a group think video. So you're going to watch this video on break. It's made by a doctor and it's talking about the different types of dialysis and why you would do one versus the other. And I don't know, I'm really excited about this video because what I'm going to do is put y'all into groups, and you have to think about maybe somebody in your family who is has multiple comorbidities, maybe a little bit older, and you have to think of some of the contraindications if that person would be a candidate for, say, peritoneal dialysis. Okay, sorry, somebody was in the waiting room. Or if they are a candidate for hemodialysis. So we'll get there, that's on the slide. Then I have a little clip from Grey's Anatomy. We're gonna watch that and then review some NCLEX questions. So I'm estimating this will probably take us an hour and a half. Let's hope this works and I can actually stay within my time frame. So here we go. All right. Oh, by the way, I was thinking actually about the person who says that they hate to give high fives. And I said to myself, I wonder if they hate it this much. So I'm going to show you this short little clip. What'd I do? Okay. Right. Okay. Oh, well, yeah. Not a good time.
I don't like the looks of him. I mean, who wears socks with no shoes?
He seems to know what he's talking about.
Okay, fine. Which way do we go?
First, you have to give me a high five, then I'll tell you.
What?
Oh, I love high fives. I'll do it.
Oh, I know you'll do it. But will he? All right, Dumpy Diapers, up high.
Nope, I don't do high fives.
Slap it, boss.
Not gonna happen.
Party on the top floor.
Nope.
Little Slappy, make Daddy happy?
That's weird.
Come on, just one little high five.
Oh, no, thanks. I'm good.
Here, just do this, but with your hand.
Thank you for that demonstration. Really cleared up exactly what I will not be doing.
Rich, it's a high five. The others lead to certain death. Get perspective.
One high five and then you'll tell us which tunnel to take, right?
So easy.
Okay, fine.
Too slow.
Too slow?
Classic.
All right. I'll let you slide with a fist bump. Whoop! Shark attack! No, 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 no. Jellyfish, ham sandwich, turkey, snowman, dolphin, helicopter, last supper, monkey in a zoo.
What?
Gear shift. Okay. Now I'm thinking we hug.
So, do you hate high fives that much? There's a little chat menu right there. I mean, how bad can you really hate high fives? I'm really curious if that, I bet that person who hated high fives is not here today. Well, that video was for you. All right, let's get, that was my icebreaker somewhat. Let's go ahead and get into our Kahoot. So I hope you have your phones ready, because here we go. Doop. Ah, ah, don't give it away. Teach. Full screen. These are some bloopers.
Okay, everybody, calm down.
Careful, guys. Watch your step. Big round of applause for ladies and gentlemen. Let's bring it out. Everyone back here. Somebody's got to put that up on YouTube quick. Yeah, have the rings.
Oh, shit.
Oh my, no, no.
23 players. Anybody else out there? I'm thinking we almost have everybody signed in. Waiting on 2 more people or 3 more people. Everybody signed in? Let me see. This one I had 30 people. Okay. I'm gonna go with it. I'm losing people. Okay. $26. I think that's as good as I'm getting. All right, let's just go with it. All right, here's your first question.
Mommy,
Shh, Chase.
do you know where my orange monster truck is?
I don't. Oh man. Okay. Do you guys want an explanation? Yeah. Okay. And I also found out you can do a little emojis somewhere on the bottom menu. You're able to do like a thumbs up or like an applause or something. But okay, so urethritis is very commonly caused in males, because males don't often get UTIs, by STIs. Gonorrhea is one that they'll test positive for. Chlamydia is another one that they'll test positive for. And the other one, oh no. There is one more STI that will cause them to have urethritis. So the answer is gonorrhea in this particular question about males and urethritis. Go, Brianna. Here's your next question. There is one more thing they have to stay away from when they currently have a UTI. Use the chat menu to see if you know that one last item. Carbonated drinks, caffeine, and trying to find where my chat menu is. Oh man, I actually can't see your responses. That's fantastic. Are you guys even responding? Ah, chat. I don't even know where it's coming up. I don't know what your answers are. This is good. I wonder if,
At the bottom where you can share your screen, do you have the little bar that comes up that says chat, mute, record, participants, invite? That's where we're clicking to get our chat menu, and then it's popping up in the middle of our screen.
okay, let me put that over there. Thank you. Good times. Tea, alcohol, alcohol, yes. And then the last random thing is tomato juice, like V8. I know. And I'm thinking, who still eats, drinks tomato juice? But apparently there are some. And that is considered as a bladder irritant if you have a UTI. Good. Okay. Ooh, JG's coming up. Great job. There is a pretty distinct group of patients that fall into complicated versus uncomplicated UTIs. Which one has a higher mortality rate? Type it in the chat. Which group has a higher mortality rate? And they have correct, the complicated ones. Can you give me another example of a complicated UTI or a patient that would be classified as complicated UTI? Maybe another example. Ooh, good one, Parker. Pregnant. Samantha, what trimester are we really anxious about? Yep. Good. Very good. Yeah, and males who, Jace? Okay, sorry. Oh man, sorry if you can hear that. They're trying to get me. Hold on one second. Carter, seriously? Here, come on. Hey, Mom? I think they're having breakdowns back there. What? They're having breakdowns. Okay, sorry about that. Male clients, anybody who has a UTI obstruction, anybody who's immunocompromised, they have a higher mortality rate because they have treatment failure of antibiotics and other interventions that we use. Okay, sorry about that. Brandon's doing good. Okay, next one. great. There is one other very odd symptom of that older adults will have besides explained falls. Yes, confusion or delirium, which is basically acute confusion. Good, awesome. Those are two things that as soon as your patient is acting strange or if they have a fall, please investigate and grab a UTI. Infection does really weird things in older people. Are their symptoms going to be the same as our younger adult population? In what way? I see Kristen shaking her head. In what way, Kristen? She's like, dang it. You can turn your mic on, Kristen.
I was just thinking back to us talking about the confusion, delirium. So that's really the only thing I was thinking would be different.
You're like, animal. Yeah. They are going to have more vague symptoms. Nothing like their fever is going to be a little bit on the lower end. They're not going to be as tachycardic. We're going to have like anorexia where they just don't feel like eating, maybe some nocturia where they have frequency in the evening time. So nothing's going to be this like big presentation of a UTI. They're very subtle signs. Good. Well, y'all can't slow Brianna down. Nice. Those who have pyelonephritis are going to have all of our presentations of a UTI. In addition to that, they will have flank pain and general malaise. And, well, we don't need explanation. You already told me that. Don't over-explain. If I'm not explaining enough, y'all will just need to let me know. I think this was, I was trying to get that we would just follow the sequence of performing an assessment. And no, we don't exactly auscultate over the kidney area. I don't know what you would hear on the backside. Okay. Yep, sounds like a kidney. And I want very specific answer on this one. Oh man, all right. Do you know what the spread means of answers? The question wasn't good enough, or you guys just took a good guess because you weren't sure. All right. we may have positive nitrates or positive hematuria, but unless there is a high enough bacteria count, then we honestly will not run a culture. So having that 100,000 plus bacteria is very significant. Now, the book does actually go into detail about if you have a clean catch, that bacteria count is considered positive at 100,000 versus you have a somebody who's been catheterized, like their positive count will be at like 10,000. But overall, I want you guys to remember the 100,000 value. That's probably what NCLEX is going to test you on. Maggie says, so at the ER, they make most people pee in a cup. Are they looking for something abnormal and then culture first? Oh, in fact, Maggie, is it sort of like you have symptom, like any kind of GU symptoms? Here's a cup, pee in it. Is that right? Yeah. Pretty much. What we're going to do is, see if they have a high bacteria count, and then we're going to run it from there. But the bacteria count is usually off of a another lab test. It's not like a dipstick thing. I should have asked that whenever we did a lab tour. Okay. Oh, good. Nice job, everybody. That one, I guess, wasn't much of a challenge. Ooh, Liz. You're in a nice answer streak. Next one. Most sensitive, most preferred test goes to CT scan, usually without contrast. Jessica takes the lead. And this is for Squishy. Close fourth. Nice, that is correct. Five players just hit answer streak of 3. Got 6 more. Ooh, nice job, everybody. For bonus points, how long are you on this medication? Type it in the chat menu. How long are people typically on this medication? Looking good on one of those answers is correct. It's about 2 to 3 days. 2 to 3 days, usually 3 days. There is one limitation with a urinary analgesic. A patient cannot have current kidney failure because this is also a little harder on the kidneys. You know, if they're uncomplicated UTIs and there's, you know, good kidney function, you're allowed to put them on this drug. But otherwise, you might have to do other forms of pain management. Good. Okay. Good. And if you weren't sure what the disulfiram effect, you know, and the cross-sensitive sulfur drugs and the crystal urea, where do those selections actually go with? Rewatch your Panapto about the antibiotics to see if you can better fit those facts in with the correct antibiotic. I'll make you work for that one. Nice. Awesome. I'm very proud of you guys. Oh, good. Nice job. Here we go. Yep. What is the benefit to wearing cotton-based underwear? Right, breathable. It doesn't hold moisture in. Too moist of an environment can put somebody at risk for UTIs. Great. Good, good, good. Look at Michaela. Come on up there. CH too. Jessica's tough. What has probably occurred in this situation? Why do we need another UA? Maggie's got the correct answer. Not so much the super infection, you know, where we would be looking for like vaginitis or something, but these are broad spectrum antibiotics and they treat a lot of the UTIs, but sometimes we will go ahead and just order somebody a very popular drug. And if they still have symptoms, that means, you know, one, we should definitely grab a culture, but two, maybe they have a different strain of bacteria that is causing their symptoms that that drug doesn't cover. So they do another one. All right. Good job, Jessica. Oh yeah. Cephalosporin, it is a 4th generation antibiotic, and or cephalosporin, it's a 4th generation. Oh man, let me back that up. Okay, Ancef or cefalozone is a 4th generation cephalosporin. It's considered a broad spectrum antibiotic. It does cause some pretty bad diarrhea. So to help patients with this GI side effect, we encourage them to take lactobacillus, or they can eat Activia, which has lots of that healthy bacteria inside. We'll go and try to counterbalance so they don't have diarrhea. Good. That Say It Out of the Sun one is really a big one for somebody on a fluoroquinolone drug, like ciprofloxacin, Levaquin. Good. Okay. I think we got 1 or 2 more. Oh, 1. Oh, for the patient 2. I think it's supposed to be report. Most important for the patient to report. Right. This one is a big anticholinergic medication. And so we've got some side effects here. There's 4 of them. Can't. Type that in. Can't. C. P. Spit. Yeah. And very nice. Well said, Angel. So the big side effects of any anticholinergic drug or drug that has anticholinergic effects is they can't see, can't pee, can't spit, can't yes, poop. So this person is having a side effect that is unfavorable of oxybutynin. Good. That is all for that one. Let's see. CH. Nice job. Oh, and I think I saw Angel, you were a close second. All right, good job, everybody. What time is it now? 9:40? I think we have enough time for this one video here. So stretch your arms, because I know you've been thinking, is this going to go on forever? It will not, so just give a good stretch, and let's go ahead and review the chronic kidney disease, patho, and some complications. And yes, I can definitely post a Kahoot, not a problem. How much you willing to pay? Nothing? Okay. You got me.
We are being censored. America's news outlets no longer provide the truth. I'm Joshua Phillip, senior investigative reporter with the EPOC.
Okay.
Chronic kidney disease is a broad term that includes subtle decreases in kidney function that develop over a minimum of 3 months. In contrast, acute kidney injury refers to any decrease in kidney function that happens in less than 3 months. Now, the kidney's job is to regulate what's in the blood. So they might remove waste or make sure electrolyte levels are steady or regulate the overall amount of water. And they even make hormones. The bottom line is that the kidneys do a ton of stuff. Blood gets into the kidney through the renal artery. And once inside, it goes to tiny clumps of arterioles called glomeruli, where it's initially filtered. And the filtrate, which is the stuff that gets filtered out, moves into the renal tubule. The rate at which this filtration process takes place is known as the glomerular filtration rate, or GFR. In a normal, healthy person, this is somewhere around 100 to 120 milliliters of fluid filtered per minute per 1.73 meters squared of body surface area. This value is slightly less in women than men, and it decreases slowly in all of us as we grow older. One of the most common causes of chronic kidney disease is hypertension. In hypertension, the walls of arteries supplying the kidney start to thicken in order to withstand the pressure, and that results in a narrow lumen. A narrow lumen means less blood and oxygen gets delivered to the kidneys, which leads to ischemic injury to the nephrons glomerulus. Immune cells like macrophages and fat-laden macrophages, called foam cells, slip into the damaged glomerulus and start secreting growth factors like transforming growth factor beta 1, or TGF beta 1. These growth factors cause the mesangial cells to regress back to their more immature stem cell state known as mesangioblasts. And then those mesangioblasts secrete extracellular structural matrix.
There we go.
The most common cause of chronic kidney disease is diabetes. In this situation, excess glucose in the blood starts sticking to protein, a process called non-enzymatic glycation, because no enzymes are involved. This process of glycation particularly affects the efferent arteriole and causes it to get stiff and more narrow, a process called hyaline arteriosclerosis. This creates an obstruction that makes it difficult for blood to leave the glomerulus and increases pressure within the glomerulus, which leads to hyperfiltration, essentially pushing more fluid through. In response to this high pressure state, the supportive mesangial cells secrete more and more structural matrix, which expands the size of the glomerulus. Over many years, this process of glomerulosclerosis once again diminishes the nephron's ability to filter the blood and can lead to chronic kidney disease. Although diabetes and hypertension are responsible for the vast majority of chronic kidney disease cases, there are other causes as well, including systemic diseases like lupus and rheumatoid arthritis, which can also cause glomerulosclerosis. Other causes, though, include infections like HIV, as well as long-term use of medications like NSAIDs, and toxins like the ones in tobacco. Now, normally, urea in the blood gets excreted in the urine. But when there's a decreased glomerular filtration rate, less urea gets filtered out, and therefore it has nowhere else to go besides the blood. And so it builds up in the blood, which is a condition called azotemia. Azotemia can cause general symptoms like nausea and loss of appetite. But as urea levels really build up, they can affect the functioning of the central nervous system, causing encephalopathy. This results in asterixis, a tremor of the hand that kind of resembles a bird flapping its wings, and is best seen when a person attempts to extend their wrists. Further accumulation can even progress to coma and death. This buildup can also cause pericarditis, which is inflammation of the lining of the heart. In addition, there can also be increased tendency for bleeding, since excess urea in the blood makes platelets less likely to stick to each other, and so there's less clot formation. Finally, in some cases, someone can develop uremic frost, where urea crystals can deposit in the skin and they look like powdery snowflakes. In addition to getting rid of waste, the kidneys play an important role in electrolyte balance. Potassium levels are particularly important, and normally the kidney helps with potassium excretion. In chronic kidney disease, though, just like with urea, less potassium is excreted, and so more builds up in the blood. And this leads to hyperkalemia, which can be problematic because it can cause cardiac arrhythmias. Another key role of the kidneys relates to balancing calcium levels. Normally, the kidney helps to activate vitamin D, which then helps to increase absorption of calcium from the diet. With chronic kidney disease, though, there's less activated vitamin D, so less calcium is absorbed into the blood, which results in hypocalcemia, low calcium levels. As calcium levels in the blood fall, parathyroid hormone is released, which causes the bones to lose calcium. Over time, this resorption of calcium from the bones leaves them weak and brittle, a condition known as renal osteodystrophy. The kidneys also release key hormones. For example, normally when the kidneys start sensing a lower than normal amount of fluid getting filtered, they respond by releasing the hormone renin to increase the blood pressure. In chronic kidney disease, the falling glomerular filtration rate leads to more and more renin secretion, which leads to hypertension. Now, remember that hypertension is a cause of chronic kidney disease itself, so this creates quite the vicious cycle. Finally, the kidney also secretes the hormone erythropoietin, which stimulates the production of red blood cells from the bone marrow. In chronic kidney disease, erythropoietin levels fall, and this leads to lowered production of red blood cells, and ultimately anemia. The diagnosis of chronic kidney disease comes down to looking at changes in the glomerular filtration rate over time. Chronic kidney disease might be suspected with a GFR of less than 90 milliliters per minute per 1.73 meters squared. Irreversible kidney damage might happen with a GFR below 60 milliliters per minute per 1.73 meters squared. To confirm the diagnosis, a kidney biopsy can be done to look for changes like glomerulosclerosis. Treatment for chronic kidney disease often involves managing the underlying cause. In severe situations, dialysis or a kidney transplant might be needed. All right, as a quick recap. Chronic kidney disease is when the glomerular filtration rate falls below 90 milliliters per minute per 1.73 meters squared over at least 3 months. Chronic kidney disease is mainly caused by diabetes and hypertension, and complications include electrolyte abnormalities, toxin buildup, hypertension, and weak bones. Thanks for watching. If you're interested.
Okay. So, what is one of the reasons that the kidneys fail? Use the chat menu. What's one of the reasons that the kidneys fail? Yay! And it says rheumatoid arthritis, toxins such as tobacco, good, smoking. Ooh, trauma, yep, they can fail because of that. Not enough blood going to them. Good, very good answers. Okay, so now I want you to type it in, but don't hit enter just yet. Name a complication from a failed kidney. And you can be specific or you can be broad, but I'd like for specific if possible. So don't type it in just yet, or don't hit enter just yet. Just type it in. What is a complication from a failed kidney that we are going to see or maybe notice on our patient? Maybe in an assessment, maybe in a lab value. All right, did you type it in? Okay, hit enter. Ooh, proteinuria, ultramental status, right? They have encephalopathy. Good. Do you remember that name of the assessment whenever they have like a wing flapping with their hand? Starts with an A. A complication, maybe not so much urinary retention, that could lead to urinary retention could cause chronic kidney disease, but I don't know if chronic kidney disease causes urinary retention, so it only goes like one way. Azotemia, good. Azotemia, Gabriel, is by definition what? Too much of what in the urine? Are you able to go specific? It's a very particular waste product. Yay, urea. Cool. Good. Let me look through the answers again. I got hyperkalemia. That's a good one. And Google, let me make sure I say this right. The flapping of the hand motion. Asterixis. There we go. That's whenever you ask them to grab something and you notice that their hand is shaky like that. That's a very good assessment skill to know if somebody has way too much BUN or urea in their blood. They have uremia. Great. Excellent, everybody. Okay. Now let me show you my next slide. Okay. Thank you, Krista. All right, so here's what I'm gonna do. I'm gonna have everybody go on like a 10-15 minute break, and inside the calendar invite was a video. And here's what you need to do with the video. So within that 10-15 minute time period while you're on break, watch the video yourself. Then I want you to think of somebody in your family who has multiple health conditions or maybe is of advanced age, and the video mentions some pros and cons and contraindications for dialysis, one type or the other. And you maybe be the patient advocate or the nurse advocate advocating for your patient, your family member. What dialysis do you feel would be a best fit for them? And you're going to discuss your answers and why you feel that is. I'm going to go ahead and put you in your groups. And then basically in roughly 20 minutes, I will meet you back at the main one. So let me go ahead and assign groups, and then you'll take a break and discuss it and watch it. And let me find my menu. There we go. Breakout rooms. I want you guys in 5 rooms. That's 6 rooms. Okay. All right. There you go. Go to your rooms and go on break. I'll see you roughly in 20 minutes. And I'm just checking everybody who's left here. Is there any questions, or do you need help finding like what to do next or where the buttons are? You guys are okay? Okay, just relaxing on your break. That's good. Welcome back. Did the breakout groups work appropriately, Alexi?
No, I got kicked from mine. I'm just trying to figure out how to get back in.
Oh, let's see how do I do that. That's a good question. You know what? I'll put you in a different one. How about that? And I'm going to do the same for Michaela. Oh, she go back in. Alexi, did you see an invite?
No. I had one the first time, but I don't have one this time.
I'm going to move you to another group. Is it showing then?
No, I don't have anything again.
What if you click on your video on that little 3 dots, the ellipses?
No, it says that I can mute my audio, stop my video, rename, or I can hide myself.
Okay.
I mean, I can hide myself if you want.
No. Oh, how did it do that? And when I go to try to break out rooms again, manage participants. Ooh. Okay. Well, poor Elena, she's all by herself.
Oh, what
Michaela's
group
having,
is she in?
Elena was in group 6, and so either they're done or she just hasn't come back to the main group, or everybody got kicked out and she's all by herself. Oh, okay, looks like time is up. All right, I'm going to time up. I'm closing. Okay. Let's see. Let's close the groups. Oh, I see. It sends a warning. They have 60 seconds to come back. I kicked everybody out of their room. Come back to the big room. Come back to the living room. All right. Okay, I think we are all here. I'm looking at the breakout room number 1, where I had Hannah, Jordan, Kenny, Lexi, and Maggie. What dialysis did you guys feel would probably be best for your family member?
For the dialysis type, I chose that my grandmother would prefer to use the peritoneal dialysis treatment due to the fact that she's able to self-manage. So she's able to self-manage like her treatments and stuff, as far as like taking her medications and making sure that she's getting everything done throughout the day. Also, she does not drive, so I would believe that having to go to a clinic or a hospital would be an issue for her, due to the fact that transportation is not, that she doesn't have access to transportation. So.
Wow, that's a really good thing to think about. Did anybody in your group, Kenny, feel that hemodialysis would be a better option for somebody?
I don't know if anyone chose hemodialysis. Yeah.
Okay, cool. Thank you. Breakout room 2, which was Brianna, Dion, Kristen, and Nastia. How about your group? Did we end up choosing one over the other?
So we really only talked about Dia and I. We didn't really get a lot of time, I think, to discuss everyone's like family member that we could think of. I know as far as my situation, I don't know if Dion wants to talk about his. So my father is already very sick. So if something were to happen, and I don't know if we could choose this as an option, but it was one of the options in the video, would be either to let it play its course, because as far as quality of life is concerned, in my father's situation, it wouldn't necessarily be beneficial to go through the hours and the commitment of time that dialysis requires, and all of that for the little bit of quality of life that would improve. And or the other option was, a family member could potentially do a kidney transplant if anyone was a match. So,
Ooh, that's a hard decision to make. Oh man, how do you answer if somebody asks you, so by the way, my kidney's failing, do you mind checking to see if you're a donor? You're like,
if it's my family member, I don't really think twice about it, because I'm healthy enough for surgery. I think that if I had an immunocompromised system, or if I had something where, it was risky for me to be under the knife, I really don't mind. Like I would give like part of my liver, I would give a kidney to a stranger. I really don't care. Like, I mean, I don't need it, right? Like it's fine.
Wow. Dion, did you have comment before I go to the next group?
Yeah, we end up discussing because I was just saying that my mom has hypertension, which scares me. Like she was actually admitted to the hospital for 2 days and watched one time because her blood pressure got like 230 over 150, and they were like, "Ma'am, that is stroke." Like one of the doctor basically said, "I'm surprised you haven't had a stroke," and like. And I took her to the hospital because, for one, the blood pressure was like way too high, and then she started saying she had a headache, and I was like, "Well, that's not good." And then she already has like mild neuropathy sometimes that scares me, because I was telling them one time, like I was trying to play a joke while she was like laying on the bed. I tried to like just poke her foot, but she didn't feel it. And like I kept doing it, like she's gonna notice this eventually. And then like she's like, "Well, I didn't even feel that," and it scared me. And I was like, and then when we were actually at the hospital, because her blood pressure was so high and everything, they end up doing like a urinalysis on her. They even took apparently like x-rays of her kidneys. They really like focusing on the bond and creatinine. They were trying to like really see like if anything happened, but nothing, shockingly, and thank God, nothing came back wrong with her kidneys. No specific gravity change. Like nothing major. I think they did say they found like white blood cells in it, which they thought she maybe had an infection going on, but like they said overall her kidney function was actually fine and perfect. And they said, and the doctor was like, "Your kidney function is actually really great for your hypertension and your conditions going on." He was like, "I'm really shocked." And I was like, "What do you mean by shocked?" Like, do I need to prepare myself? And then overall, I was like, if she did have to go on dialysis, which I pray she never does, I prefer her to stay home and do it, because if I live nearby or so, or even then if I can instruct her over the phone, going into the nursing field, like I could help her with that as well. Plus going to the hospital 3 days a week for 4 hours, that's just too much. Like I don't feel like sitting there. I don't even like going to the ER, because I feel like you wait forever in the ER, let alone going to the hospital to just sit there for 4 hours and
you would
like.
You would go to like a special outpatient dialysis clinic.
Oh, I mean, I know, but it's just like the thought of just spending the whole sitting process or like going through that. I feel like that's more torturous, and I feel like that can make someone want like die off quicker in a way, because then they'll just like see the machine, see the blood, and like they may not like the sight of it, or I mean, they may not like the sight, period. But I feel like just doing that is going to be too much.
It is. It's very hard on patients. Unfortunately, a lot of our patients are getting younger and younger being on dialysis because of reasons for hypertension and obesity. Their kidneys in like their 40s or even 30s are going out. A couple of my patients who have sickle cell, they'll have multiple sickle cell crisis, and the cells get clogged, kill the kidneys, and unfortunately, they're like 20 years old on dialysis. Let's see, breakout room 3. This is Angel, Liz, Eve, Leah, and Samantha. Is everybody a peritoneal dialysis fan, or are you a hemodialysis fan for your family member?
So we chose my dad, and I think that for him the best option would be hemodialysis. He is a non-compliant diabetic. He has gout flare-ups very frequently. So my mom also has 3 kids still at home with her that she cares for, and she's a nurse, so she works full-time. So I originally thought that at home would be best because he is non-compliant and he doesn't like to do stuff, so I figured my mom could help. But then I think that would be too much stress on her, caring for 3 kids, working full-time, and trying to make sure that he gets all of his treatments several times a day, rather than driving to the clinic and getting treatment a few times a week. I also thought of just doing nothing, because my father's very non-compliant. He's an advocate for quality of life over quantity of life. So I don't even know that if his kidneys were to fail because of his diabetes, that he would want to do dialysis.
You know, it's the challenging part about kidney failure, because it's very slow and insidious, and usually people don't die of, say, high potassium and your heart stops. That would be actually sort of a nice way to go, but they die of pulmonary edema. And so as they're like suffocating, can't breathe, oftentimes patients are like, whatever you have to do, because I can't breathe. That's a very scary place to be. And so I don't honestly think, in the conversations I've participated in, that doctors and maybe nurses do a really good job of just sharing what that life is like. And so I try to do as much education as possible when that person makes that decision to choose dialysis or not. But if they choose not to do dialysis, then we would just honestly put them on morphine drips and palliative care, stuff like that. But that's a good thing, Leah, just to encourage you and anybody else in that situation to bring up, because oftentimes patients lose their level of consciousness because they got such bad pulmonary edema. We intubate them. Now they can't speak for themselves, and the family usually is the ones who decide, yes, let's go ahead and do dialysis. Anyway, that's a lot of pressure on your mom and you too. Any other comments in breakout room 3?
I like that you added that. I didn't know that that's how the end usually looks for people dying of chronic kidney disease or acute kidney disease. Yeah,
very, I mean, I'm not going to say never, but in my personal experience, it has not been the heart stops from hyperkalemia. It's the fact that they're drowning internally, and everybody gets desperate because their heart is so overwhelmed. They have that pulmonary edema. It's ugly, just to be honest.
Sounds like it.
Yeah, so self-care, take care of yourself. Thank you for sharing, Leah. I really appreciate that. That's important. Maybe breakout room 4, I've got Ancy, Chloe, Krista, Elisa, and Jessica.
Well, for me specifically, I'm kind of like with Leah. My dad's in kind of the same situation. He is a diabetic type 2, poorly managed. His A1C is always like horrible. And I know because I get onto him all the time. I'm like, you know what you're supposed to be eating, but he'll be like, I'm eating salad, but he's eating like a horrible fat salad, like fast food salad, you know? So, I mean, it's awful. But he's been, because of his poorly controlled diabetes, he's now having, like, he's had heart issues. He actually, within the last month, he's been to the ICU twice, and they had to put another stent in his heart. You know, there's been times in the past where he's also gone to the hospital because they ran test on him, and like the medications that they had him on for his diabetes was causing his kidneys to fail. So like he's been like on and off like metformin and stuff like that, because I know it's really hard on the kidneys. So for my dad, I would think, because he likes to have control and be in the comfort of his home, he would probably want the peritoneal dialysis and probably do the one at night. But because he doesn't manage his diabetes anyways, I don't think he would be able to manage it without someone being there to enforce it. So that's the only thing, is like, I know what he would like to do for flexibility and control, but would he keep up with it? So I'd probably be in the same boat. Like, he'd probably let it kind of take its course for quality of life. Or I'm sorry, yeah, quality of life over quantity. So it's kind of hard. So
Especially, yeah, I know. I understand that as we pursue health and learning all about what's the complications of these disease, and then we have our loved ones living it out and walking it out, we're like, no, like there's a train coming.
Yeah.
And oftentimes their motivation comes from usually a significant health event. My father is a very heavy alcohol abuser, and I can just see it right now. He's not going to die just of liver failure. It's going to be a stroke. It's going to be in nursing home for many, many years, decubitus, like, the end is near. And my family's like, oh my God, Lydia, stop. Oh, all right. Thank you, group number 5. And I know I'm looking at time here, but Alexi, Gabriel, Madison, Sierra, what did we pick and why?
So didn't really discuss it, but my dad is actually like a good candidate for I guess peritoneal dialysis. So I would pick peritoneal dialysis for my dad, because recently I brought my dad to the ER for delirium, and then they diagnosed him with acute kidney injury. So he is, I guess, that is a major risk factor for having kidney failure. So my dad can be like, he can learn stuff pretty quickly, and I can teach him stuff. I have my brother who is also a nurse. I have my cousin who works at Baptist as a family physician. So and my dad doesn't really want to go out that much, and I don't prefer him going to the hospital like 3-4 times a week, because that's just not gonna happen. And I would say, like, for kidney transplant, he might also consider that, since he's got like 9 brothers and sisters, and I hope like one of them might be like a match, and I don't think they would mind it, like, because they're very close to each other. So, but I don't really think my dad would prefer the kidney transplant, because just my dad's personality is like, yeah, I'm not gonna bother you, just let me suffer.
And Gay, what would be, say, an important lab value to check on your dad to see what stage of kidney disease he may be in?
The GFR. So I think when I check his GFR on his portal, it was like 60 or 70. So, and his bun and creatinine was like high when I brought him to the ER. So, but it went down.
Good. One real important thing to know is when we check somebody's GFR, and let's just say it's roughly about 60, and his BUN and creatinine is up. If he sustains that longer than 3 months, that's when we actually will transition the terminology from somebody has acute kidney injury to now they have chronic kidney disease. and we'll actually establish a new baseline. So 3 months is actually a really important time window when we are talking about our patients, and if they're just in like acute kidney injury, or 3 months has gone by, you're still at this GFR, your BUN and creatinine have not resolved. Now you therefore have chronic kidney disease. So that's actually one of the diagnostic indicators and criteria for our patients. So good. Thank you, Gabe. And then I think breakout room 6 was just Elena and Michaela. Anything briefly you guys would like to share? I can't see your videos all at once, so if you're shaking your head. Elena, there you are. Anything? No, okay. She's like, move along, move along. All right, great job, you guys. I really appreciate you sharing. Now I'm gonna show a video, and it's actually, I got a subscription to Netflix finally to watch that Tiger King show that everybody's recommending. No, not really. It was because of Grey's Anatomy, but I might watch Tiger King thing. And I'm going to show you very specific clips, and then I'm going to ask you questions. So please listen carefully, because in this video they're talking really fast. But I'm going to go ahead and pull it up. All right, let's make it big screen. Pause. All right, good. I'm going to go to 903. Yeah. All right, take a listen, and then I'll ask you some questions, okay? Yeah. Yeah. Oh.
Hey, Sarah. Dr. Stevens, I have to go. The doctors are here. My sister and her daughters want you all to promise them it's a good kidney. It's a good kidney. There, right? Bye.
Sarah Fremont, age 27, end-stage renal disease, on dialysis for 3 years, waiting for a kidney. She's down to her last access site.
That's the polite way of saying they've run out of places to stick the needles.
Ms. Fremont has a subclavian catheter for access. Why is this not ideal?
It's difficult to obtain sufficient blood flow through. Oh, you guys raise hands.
Frank, no spot.
Okay. Were y'all able to hear that? Give me a thumbs up if you could hear that. Yeah? Okay. All right, good. So your first question, and then you're going to use the chat menu to type this out. Make sure I have the chat menu available. Okay. Sorry. There it is. They mentioned that this is a 27-year-old end-stage renal disease patient. She's been on dialysis for 3 years and waiting for a kidney. What do they mean when they say she is on her last dialysis site? What do they mean when they say she's on her last dialysis site? Yes, no more good veins. The other sites are not able to be poked or used as access. Good. I mean, they kind of briefly said it, but I was going to just share that you only have 4 places that people can put fistulas or grafts. You have your right arm, your left arm, your right groin, and your left groin. Usually they will pick your non-dominant arm and they'll go ahead and say do like a fistula or maybe even a graft. Fistulas tend to last a little bit longer. And a fistula is where you're going to tie that artery to the vein together because the dialysis machine has to run your blood in and out super fast, and veins are not able to handle that amount of pressure. So by tying our vein to the artery, the arterial blood flow is actually going to go and kind of loop back in to our venous system, and it's going to grow and expand our veins and make them larger for whenever our hemodialysis machine gets hooked up to them and can, you know, get the blood in and out faster. But anyway, if this one fails or clots off or gets multiple infections, they actually are going to tie it off and then they'll surgically implant one here. If this one fails, they'll surgically implant one in your groin. If that fails, they'll go to your other groin. And then after that, a patient can only have dialysis through a central line place. It's a special catheter placed. And, you know, we know those are at risk for what? Infection. Awesome. And I'll get to your answer, just your questions just a second, Leah. So yes, the bad thing here too is not only at risk for infection, but sometimes just having that catheter inside, the body tends to clot more often. So occasionally the catheters become occluded, or clots form around them, and then they could release and go into our lungs. So we can have PEs. It's definitely a little bit of a struggle. So you can have 4 places for catheters, actually 6. You can do subclavians. Excuse me, these are jugulars. You can do jugulars and they will tunnel them out through your chest, or you could do some clavians. Those are very dangerous to place because oftentimes they are placed in emergency type settings and you can cause a pneumo. So they don't like them to actually place them in the subclavian vein here. We try to go jugular and then they tunnel and pop out. Okay, the other 2 are your groin, right groin and your left groin. So occasionally, peritoneal dialysis does not work for some patients, not so much as a compliance issue, but maybe they've had multiple abdominal surgeries and that peritoneum is now scarred and unable to diffuse all of the diastolate through their membrane, because the membrane, the integrity is disrupted. So patients may not be candidates for peritoneal dialysis because of multiple surgeries in the past. Okay, good. And then what was the doctor looking at, that head doctor? She was messing with the patient. What was she looking at or looking for? I don't know if you could even see what she was doing. Yours is like, replay it. I can play it. It's pretty short. Let's see, right here. See what she was looking at.
Dr. Stevens, I have to go. The doctors are here. My sister and her daughters want you all to promise them it's a good kidney.
It's a good kidney.
There, right? Bye.
Sarah Fremont, age 27, end-stage renal disease, on dialysis for 3 years, waiting for a kidney. She's down to her last access site.
That's the polite way of saying they've run out of places to stick the needles.
Ms. Fremont has a subclavian catheter for access. Why is this not ideal?
It was difficult to.
Okay. They were looking at her dialysis cath. A lot of times we call this a Tessio. The only reason we say Tessio is that's the name brand of the catheter type. Yep. Oh, no, that's okay. Yeah, we were looking for infection. Oftentimes, though, they're not going to have that island dressing. It's going to be clear and transparent, but we must, every time our patient has one, assess the site. And how often do you change a central line dressing? How many days? Is it 3? Is it 7? 7 days. Every 7 days, the dressing needs to be changed, and it is considered a sterile dressing change. So you have to wear a mask, sterile gloves, your patient has to wear a mask, and anybody in that room has to wear a mask. So bring a bunch and pass them around. All right, good. Okay. No, let's go here. All right, so in my next scene, I'm going to show you, they are arguing just a tad, and Izzy is sort of upset with this other resident. I guess there is a hospital merger, and so 2 residency programs, like basically Pensacola State and UWF, are trying to work with the same patients kind of thing. And so there was a little bit of an argument, and Izzy kind of doesn't pay attention. So I had to preface that because if not, you'll be really lost at the scene. So let me drag the mouse, and then you tell me, well, I'll ask you a question after you watch it. So 2508. Easy. There we go.
Dr. Stevens, can I talk to you for a minute?
Go ahead.
Picked up the labs for you. If you want, I can take care of the dialysis.
I've got this. I don't need a surgical bitch. Thanks.
Izzy, it wasn't personal. That stuff, it just comes with the job. I'd expect you to do the same thing to me. Outside of work, you can be friends, but inside, it's a whole different story. At least it was at Mercy.
Well, that isn't how it is here. Here, we don't just think about ourselves. We support one another. We have each other's backs. We throw ourselves in front of buses to save the lives of complete strangers. You will never measure up to the people we've lost. Let's do 140 base sodium, 37 base biocarb, and 0K bath with an ultrafiltration of 3.5 liters. I suppose.
All right, so they are actually performing dialysis because this patient's recipient or donor kidney has just arrived to the hospital, so they're prepping her for it. What numbers was she giving him? Giving the tech? Kind of just, you can even, I want to guess. Give me a guess. Right, some filtration rates, like how, and she is prescribing the diacylate. I can never say that word properly, diacylate. So every single patient, according to their lab value, will get a certain type of like bath. And what we're going to do is we're going to connect the patient, and their blood is going to come out of them. And as it runs through the machine, it's going to go through and next to this this membrane, and this membrane has a bath on the other side, and according to the concentration, to the solutes, to the sugar, it has its own composition of electrolytes in it too, and it has a whole lot to do with the ions and exchanging right and left, osmotic pressure. I mean, it gets really complex, but she was prescribing a very specific bath for that patient, which you'll see what happens in a second. So what I'm trying to say is your patient will get a bath prescribed for them, and we need to, before they go to dialysis, take a dry weight. A dry weight means you basically take all of their blankets and stuff off. Well, let me back it up. That's their wet weight. Weigh them before dialysis, and then after dialysis, you're going to get a dry weight, and you're going to calculate by their weight how much fluid you pulled off of a patient. It's kind of neat because 1 kilogram equals 1 liter of fluid. All right, so the numbers, all right, I'm going to go to 3004. Now, there's obviously a complication here. So pay really close attention to what you see here. 13, okay.
Push another 2 of Ativan now. Give me new chemistries and an EKG.
Get the crash party in here now. Start ventilating her. Croissants?
Ooh, what did we just see? Here she is getting dialysis, and she's having a seizure. Right, she is having a seizure, and he just ordered something for her seizure. Ativan, yep, he said give her 2 of Ativan. 2 what? Good, milligrams. He means give 2 milligrams of Ativan. That will definitely stop the seizure. Okay. This patient is experiencing a complication called disequilibrium syndrome. Repeat that, disequilibrium syndrome. And this is when Oftentimes their fluid and electrolyte shifts happen so quickly that occasionally a patient will just, their body responds by getting restless. They will lose consciousness, they'll go into coma, and they'll have a seizure. There is a description of like mild disequilibrium syndrome, and that can occur on a patient's first couple hemodialysis, but a way to treat that is they'll give them anti-nausea medication and slow the rate down, and it normally goes away. Now, can you see the rhythm up here? Can you see that rhythm? I know you guys haven't learned rhythms yet, but they mentioned torsades. There is one reason why patients have torsades. It's a low keep going. Magnesium. Torsades is from low magnesium. And one of the reasons I wanted to point this out is because potassium and magnesium, follow each other. So whenever potassium goes down, the magnesium likes to follow with it. So that's just a nice little to know. Yep. Potassium goes down, mag falls with it. And when you have low mag, you're at risk for having torsades, which is exactly what you see there. Okay. And let's see.
You gave her torsades? What the hell did you do to her?
I didn't do anything. You were the one who was with her last.
Paige Bailey!
I already did.
Here! All right. And then 3249. Which, by the way, I don't think we put the paddles that way. They're not both on the front of the chest. 3249. There you go. All right. Here we go. Now somebody's in trouble. Let's see, did I do the right spot? 249. Yeah, yeah.
She's alive, barely. She's still gonna get the kidney? I'm asking the questions right now, Stevens. Dr. Percy here tells me that you were in charge of Sarah's dialysis. Is that true? Yes. He also says that you are pretty upset with him. I don't see what that has to do with anything. It has to do with the fact that your mental state may have clouded your judgment, may have made you a less competent doctor, may have led you to read the labs wrong or not read them at all. Otherwise, why would you tell the tech to give Sarah a 0K bath when her potassium this morning was 3.4? You sucked all the potassium out of that woman. You stopped her heart. She's alive, but she's not getting her kidney after 3 years of waiting. Somebody else will be getting her kidney. And if we don't find her another one in the next 3 days, she's going to be dead. And you will have killed her.
Oh, lovely news. All right, let me get out of here. Oh, man. So why isn't she eligible for the kidney now? It's just a seizure. Why is she not eligible for that kidney? This one might be a hard one. I'm seeing it. She is not stable.
I want my helmet on the bed.
She is not stable at all. You have, Jace, you can't talk to me right now, bud.
I want my helmet that's on your bed.
It's not on my bed. Go, Jace, go. He wants a helmet that's on my bed. I have no helmet on my bed. All right, yes, you have to be stable for surgery. This patient was not, so that's why they have to pass her up for another recipient. Okay, very good. Now, I was just going to point this out. I am not sure why she has 3 days left to live. You know, why they have to find a new one or she can't live. I'm not really clear on that one. Oh, yeah, trauma. I like that. All right. Let's get your phones out. These are our post little questions, and then we're going to be wrapping it up. Thanks, Krista. Actually, Krista had another question up here. What was it? Everybody answered? Let's see. Oh, nope, nope. No way. Yeah, let me close those up for just a second. Total results 12. That's what I was looking for. All right, let's see if I can get some more responses. $18. I'll be happy if I can just get to 20. That's all I want for Christmas. 20 responses. Yeah, okay. That works for me. So let's show what we're looking at. All right, and show correct. That one is our correct one, nausea, vomiting. Peritoneal dialysis, high risk for infection, high risk for developing constipation. And there's a problem with that because oftentimes constipation can occlude the inflow and outflow of fluid. So we have to make sure our patient is really, eating well, having regular bowel movements. Otherwise, their one lifeline, peritoneal dialysis, is not going to work. So oftentimes for complications, we'll hear hypoactive bowel sounds. And then this would be correct if it was tachycardia, and that would be evidence of infection. And they probably are going to have a decreased urinary output. They still pee though, sometimes. All right, good. Let's go to the next one. Here we go. Ooh. Oh, shoot. There we go. Krista, can you turn your mic on while people are still answering?
Yes.
Hey, so your friend's son had constipation and that would allow...
Oh, no. He was diagnosed in utero with polycystic kidney disease. So when he came out, his kidneys weren't working. And they ran out of sites on him to do dialysis. And he ended up getting peritonitis. And he ended up passing away like 3 months after he was born.
Oh, wow.
Yeah, it was pretty sad, but that's why they couldn't do dialysis on him anymore. His lungs were underdeveloped because his kidneys weren't producing amniotic fluid, or he wasn't swallowing it because, you know how they like drink it and then they excrete it and it's like a cycle. So his lungs were extremely underdeveloped. And so, yeah, it's really sad. I don't know how she did it because, like, I don't know, because all this stuff with kidneys and the polycystic kidney disease. It's actually one of the reasons why I wanted to become a nurse, because the nurses she talked to me about them and how they supported her through this time, and just like how they all came to the baby's funeral and stuff like that too. So it was just like, it was one of the reasons why I wanted to become a nurse, because my best friend's baby.
Oh, chill bumps.
Yeah.
Wow.
I know.
And I know a lot of us actually have very similar reasons why we come into nursing, for, you know, experience in the past, because you want to help and you want to know what to do. Awesome. Let's show our responses. You guys got you guys got that. Okay. Well, that was no surprise. Too easy, I know. Let's try the next question. Here we go. All right, 8 results, 10, 11, good. $19. Why does it go down? I will never know. All right, let's see what our responses are. Ooh, look at that distribution. And here's our correct answer. Ta-da, down there. There's a really cool table in your book, chapter 68, and it actually talks about some of the dietary restrictions if you're on, you know, just chronic kidney disease or you have uremia. One if you have dialysis, and another one if you have peritoneal dialysis. And it's really kind of neat to see that people with peritoneal dialysis have the least restrictions, if not any. They really don't have any. Let's see. CAPD filters client's blood through not an artificial device, but through the membrane. Oh. Oh, no fun. What did I do there? Okay. Sorry. Man. I forget what I had it listed. Darn it. Okay. Samantha's like, that's not right. Yep, sorry. Yep, you're not crazy. I think this is one of my last ones. That's funny, Lexi. It's like a race. Who should we bet on? The bad thing is in this mode, I can't see how many responses I have. 19. I think we're pretty close. All right, y'all ready for the right answer? Ta-da! So when somebody first, oh, how funny. You don't want to be wrong. When we insert this catheter and we're going to pour in a liter, maybe 2 liters into the abdomen at one time, it is really uncomfortable. We have to let our patients know that this pain is just because the abdomen is learning to accommodate all of the extra fluid, and it's not indicative of a problem. So they will feel very uncomfortable for the first week, and then their muscles and skin is going to stretch out and be able to tolerate so much fluid in. What color should my effluent be? An effluent is the outflow of the diastolate in the waste. What color should that be? Yep, pretty much Leah's got it. It's going to be yellow. It's going to be clear and frothy. Frothy, like bubbly at the top. That's fine. That's not a problem. I would probably expect it within the first week of the 2 placement to be pink. It's going to be pink. That's because of the trauma from them putting it in, but that kind of goes away over time. What I would not be okay with is white, milky, brown. Ooh, what does brown mean? What if you see brown? Brown effluent. Yeah. Leah, that is right. Yeah. You have bowel perforation. So, oh my God. Can't look at milk the same. All right. So, educator patients, what is the normal? What is the expected normal, especially in the first week, so they don't freak out when they see pink or a little bit bloody? Good. All right, that is all I have. That is the end. Please grab your phone and do a Cadley for me. I put it at the end this time to see who was going to stick with me. Grab your phone. You probably have already done it. I threw in a little renal take-home quiz. It is sitting in the module for the kidney stuff, the renals. Did 10 questions, and the answers are there too, so you can check yourself, and hopefully everything will be fine. I have a bunch of questions posted in Evolve. I was working on them. If you did it this morning, that's fine. Oh, and if you checked in at earlier today, that's fine too. No penalty. Not today. So Evolve questions on kidney disease are going to be posted today, but I do have everything for reproductive and bladder related up already. Let's see, what else is up? Oh, I had a question from Darby. It was Darby or Darcy? I think it was Darby. So Darby asked that, what about the narrated PowerPoint that involved dialysis and all of those different interventions? I'm actually updating it. I felt like it was kind of old, not to mention I had a lot of ums and pauses, so I'm going to make it better and improved and get that posted. But the first half of chronic renal disease is up there. That second half about renal replacement therapy, that's what you're going to get today. Okay, I have been looking over the Google clinical form makeup, the answers, and I tell you what, how about I'll give you guys up to 2 attempts to try to get your answers in. A lot of people did not say select all that applied, where that was an appropriate option. I did make some adjustments about the bowel movement in DocuCare and about the situation background, the background part and the S-bar. It actually, well, you'll see. But you can take it again if you want to, and we are planning on transcribing those answers over into your DocuCare. Oh my God, not into Canvas. All right, last but not least, before I get to your questions, a student asked about how in the book it mentioned that tamsulosin and doxazosin is a good combination for patients who have BPH for drug therapy. And then in my narration, I mentioned tamsulosin and what is it, the drug? Finasteride and tamsulosin. I think I might have just said that wrong. Okay, let me go back. Back it up. The book mentions doxazosin is good with finasteride for BPH. They are correct. In my narration, I mentioned that tamsulosin and finasteride are good for BPH as long as a patient is on a alpha blocker, which tamsulosin, Flomax, or doxazosin, which is Cardura. As long as they're on one of those, we're going to get the really good effects on the prostate. Okay. Oh, and I think I'm going to look at my questions. We like Zoom better. Good. I do too. When I found out I could do breakout groups, I felt like this was a better option for us. Superlative quiz. I am so glad you brought that up. I was wondering when I should mention that. So typically at the end of the semester, I have everybody vote on the who's who of the class, and I have prizes that I would give away in class. They're like really funny prizes, so I'm not really sure how we're going to give the prizes, but we can at least still do the voting. I will update our superlative roster, so I bet it's looking like last semester's is still there. So I'm going to edit those, and I'll get an announcement sent out to you when you can go and vote on, say, who is most likely to marry a doctor in the class, or who is the biggest adrenaline junkie in the class. I'll get those out to you guys. It's just fun, and I know I don't have actual prizes to give you, but we can still make some recognition happen. Okay. The chronic. So Nancy asked about the chronic renal disease lesson video. Well, the PowerPoint. So I ran into a problem. I actually have to contact IT because I uploaded it like Friday afternoon. Apparently, I am out of data in Canvas. Uh-oh. My internet connection's unstable. I'll just keep going. I am out of data, so I have to contact IT because it won't allow me to add any other files inside my Canvas. That is a problem. And a blueprint. I better be writing these down. Superlative quiz and blueprint. Yes, I actually have the blueprint ready. I just need to distribute it. And evolved questions, they are ready. We just need the chronic kidney disease evolved questions, but the reproductive are there. The bladder infection are there. Yes. All right. Anything else before I let everybody go? Was this better? I hear we like Zoom. I can use Zoom again.
Miss Tones.
Hey.
Sorry, I just had a question about the clinical, because like when I submitted the Google form, specifically for the ATI, when you submit the certificate, it still marks it wrong.
Oh.
And then also for the DocuCare part, when you give the answer, when you copy and paste for the pain, it also marked it wrong.
Right. It actually flags on my end that I have to manually go and review it.
Okay. All right. And so whatever grade that we get on that is what's going to be our clinical grade?
Yeah.
Okay.
And just to, remind everybody, the clinical grade is really just, it's a pass-fail course. And so, the big question we're looking at is, are students showing up, to class? Are they participating? Are they submitting work? Honestly, like if you do get like a 70 and it say drops all of your assignment average, like it's not a grade that's real.
Right. Well, I guess I was just for this particular assignment, since you have to like make a decent grade on most of the clinical assignments in order for it to be a pass, what's the baseline for that? For the
baseline for all of your assignments?
I guess, yeah. Like what score do we need to get at a minimum to pass this clinical assignment, I guess is what I'm asking.
I would aim for a 75%.
Okay, so stick with that.
Yeah.
Okay.
But I will say, that is definitely not a ticket to, oh man, my average is so good, I can just walk away from all the assignments.
Oh, no. Yeah, no. I definitely am gonna like take it again. I was just, I don't know. I was just trying to figure out because I got an 88, but I was confused with the 2 questions.
Mm-hmm.
But now, since I know that you grade it, then I feel a little bit better.
Yeah, I started to go in and like adjust it, and then I was like, wait, if they go in and take it again, then I would have to go in again and readjust those to answer. So I was like, I'm just gonna make an announcement and wait.
Okay. Yeah. Thank you.
Mm-hmm. All right. ATI fundamentals. Let me look at Nancy's question. Is the ATI final going to be ATI fundamentals or cumulative? Okay, so the final exam is going to be the ATI one. And the extra exam, where it's going to drop your lowest grade, be it exam 1 or exam 5, whatever it may be, That one, that exam 6 is going to be cumulative. And the ATI one does get curved. So if your base score is like a 70, usually it gets thrown up 10 points based on the whole class's performance. 10 points, 12 maybe. So you'll end up with like a 80 or 82. Yes, I will definitely provide a study guide for the cumulative. I actually have not sat down to think about the cumulative, but I've basically been told all of the courses are offering something similar to students, and that, you know, and I agree, it would be probably a good thing to do as well for students, but I have not sat down to even think about what I'm going to put on the exam yet. Everything, we'll put everything on there. Yeah, there'll be a study guide. All right, so any other questions? Last call. Right, happy Easter, everybody. Hopefully got some candy from the Easter Bunny. Have a great day. I'm gonna go ahead and sign off, okay? Thank you, bye. Okay, get out of everything here and stop recording.